Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and delve into the challenges and impact of each technology in practice. This is the Medtronic MedEd Learning Experience. No monitoring system should be used as the sole basis for diagnosis or therapy, and they are intended as an adjunct in patient assessment. Reliance on a single monitoring system alone for patient management is not recommended. The contents and conclusions of the following programs are solely those of the speakers unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers receive funding from Covidian LP, a Medtronic company, for this speaking engagement. Medtronic's medical education programs are offered to provide attendees education on FDA-cleared indications and use of our products when applicable. For this segment of the series, a discussion on patient safety in procedural sedation. Are patients coming for procedural sedation sicker? To help answer this question, our procedural sedation nurse, Linda Erfle, and gastroenterologist, Dr. Ashish Chawla.
Okay, Dr. Chawla, I often hear my staff complaining about how sick the patients are who come to endoscopy. Is this true? And what's changed in the past 30 years that make our patients sicker?
That's a good question. Unfortunately, over the past 30 years, our patient population has truly got sicker. One of the best predictors of how sick patients are during procedural sedation is the rate of obesity in the population. And if we look at the National Institutes of Diabetes and Digestive and Kidney Disease, or the NIDDK website, their statistics, it's kind of startling. The prevalence of obesity is absolutely increasing. And if you look over this chart, this is the age-adjusted prevalence of US adults that are 20 years or older. And you can see that from 1999, 2000 to 2017, 2018, the prevalence of obesity has clearly risen. So currently, there's about 42.4% of adults in 2018 that had obesity. Now, one of the questions that I get asked is, okay, obesity is present, but what about severe obesity? Or this idea that the BMI is greater than 40. So these patients are clearly at risk for obstructive sleep apnea, heart disease, respiratory complications, and even more cancers. So again, there's been a marked increase, and it's actually more than doubled between 1999, 2000 to 2017, 2018. So the prevalence has gone from 4.5% to 9.2% in the United States for severe obesity. Now, if you look at this data, what's striking about it is it ends in 2018, but we're now in 2023. The NIDDK predicts that in the future, when this next survey is done in approximately 10 years, obesity will be 50% prevalence. So over half our population will be obese, and about 14 to 16% of our population will be morbidly obese.
Okay, this is awful. I know now that we're getting heavier, but does this actually translate to more illnesses?
Yeah, as obesity has increased, so has comorbidity. And that's not kind of surprising data, Linda. We kind of see it. What has happened is essentially the majority of Americans that used to have one or two comorbidities, it's increased that they have two or more comorbidities. So if we evaluate data from 1988 and again compare it to 2014, what we find is about 60% of the patients that are age 20 or older have two or more comorbidities. And if we look at patients that are 65 years and older, and again, who is this representing? These are the patients in cardiac cath labs. These are the patients coming in for our colonoscopies. The prevalence is actually over 92%. So they have multiple comorbidities at this state. Next question is, well, is this just a US thing? Are we just getting sicker here? And the answer is no. It's European as well. United Kingdom database, again, looking at patients with heart disease, between these same years, 2000, 2014, what we find is there's a four-fold increase in patients who have 5 or more comorbidities. So again, patients that are heavier, patients that have multiple comorbidities, these are the guys and gals that are entering our procedural sedation suites. So when that happens, we see more acuity.
Okay. Again, this is depressing. So let's talk about something better and talk about the pandemic. How has the COVID pandemic impacted our population?
Again, it's going to get more depressing here because what really happened with the COVID pandemic is we had a number of patients that were just completely undertreated. We had far less immunizations done, far less cancer screenings done. Even our ER visits dropped. The people that did come in, the sickest. What's impressive is that Ned Sharpless, he was the former CDC director, at the end of his tenure basically said, right after the 3 years of the COVID pandemic, where there were no screenings done or very limited screenings done for breast cancer and colon cancer, the CDC predicted that there would be 1 million more deaths in patients due to advanced stage cancers over the next 10 years. So guess what's happening? These patients are now coming in after COVID has reduced or subsided into our ERs, into our ORs, into our procedural center suites, which is cardiology, IR, GI, and they have more advanced stage cancers and they're sicker with higher acuity.
Sobering statistics. So what are the outcomes of the sicker, older, more obese patients getting moderate sedation in NORA, non-operating room anesthesia?
Yeah, so the one thing we have to understand is that in non-operating room anesthesia, when these patients come in, as they get older, as they get sicker, we notice that their complication rate increases. The main complication rate is pulmonary complications, hypoxemia being number one, and number two being respiratory depression or respiratory obstruction. What we have found is technology that helps us with this. Capnography can recognize early, far earlier than oxygen saturation monitoring, the rate of respiratory compromise or hypoxemia during procedural sedation. By measuring the EtCO2 or the end-tidal CO2, we can actually measure ventilation and find patients before they get into hypoxemia or severe hypoxemia episodes or get pulmonary complications from respiratory compromise.
Well said, Dr. Chawla. Catching respiratory depression early is critical. And to prevent complications like something from simple retching to becoming aspiration pneumonia, we're going to need our capnography.
Please tune in next week for a new segment from this series wherever you find your podcast. This is the Medtronic MedEd Learning Experience. Thank you for listening.